All right. Well, good afternoon, everyone. My name is Marco Schmizzi, Assistant Director of Communications and Alumni Relations at the MSU College of Nursing. It's my pleasure to moderate this broadcast of conversations, which is a series of webinars sponsored by the College of Nursing. Today's webinar topic is healthcare legislation you should care about, improving access to care, and is going to be presented by Assistant Professor and Interim Director of Faculty Practice, Dr. Sheehan. I'll begin with the provider/disclosure statement. Our speaker attests that no financial relationship exists between herself and any commercial supporting entity, which would represent a conflict of interest or commercialize any presentation content. And there are no CEUs being offered today. I encourage everyone here attending today to type their questions in the Q&A box throughout the presentation, and Dr. Sheehan will have time at the end to answer. So with that, welcome, Dr. Sheehan.
Thank you, and good afternoon, everyone. I'm going to start here talking, maybe. There we go. All right. So first off, talking about access to care, what does this really mean? So the Agency for Healthcare Research and Quality, or AHRQ, uses the Healthy People 2000 and Institute of Medicine definition, saying that access to healthcare means having the timely use of personal health services to achieve the best health outcomes. They also go on to say that there are 4 components to access to healthcare. This includes coverage, your insurance, which gets you entrance into a healthcare system. So uninsured people are less likely to receive medical or healthcare and are more likely to have poor health status. Services, this includes having a usual source of care, which is associated with higher completion of recommended screening and preventive services. Timeliness is the ability to provide healthcare when the need is recognized. And we all know people's needs for healthcare don't fit neatly into the window of 8 to 5. And those healthcare issues that come up after 5 o'clock at night do not always rise to the need for an emergency room visit, but that occasionally is the only option that people have. Workforce includes the capability of and the qualifications of the provider and the fact that the provider is culturally competent to take care of your needs. Now, a couple of other components that I think are included in access to care are being geographically convenient. If healthcare is not geographically convenient, people aren't going to use it. There are many rural areas in Michigan where patients have to drive further than the next county to access healthcare. And this is an issue when we look at socioeconomic status, when people may not have reliable transportation, they may not have gas money, etc. Internet is also a component that can affect access to care. Many rural areas don't have reliable internet, and or people may not be able to afford the high-speed internet that is required to utilize telehealth services. So defining the problem of accessing healthcare, of course, we'll dive into accessing care. There is a shortage of healthcare providers, nurses and physicians both. We need improved transparency in the healthcare delivery. And Michigan laws and regulations lag behind many other states when it comes to practice for nurse practitioners. National and state organizations provide lots of support for nurse practitioners to fill the gaps in accessing healthcare. So, access to care is an issue in Michigan. 82% of Michigan counties are designated as underserved. Underserved regions are associated with higher chronic disease burden, which increases the cost of healthcare and is associated with poor care access because these patients are high utilizers of the healthcare system. Michigan's restrictive practice environment prohibits nurse practitioners from working in practices in underserved areas. Currently, nurse practitioners can't work in underserved areas where physicians are not working. These occur in rural and urban areas. There is physician supervisory language in our regulations, and I'll talk more about that later in the presentation. Nurses need to be positioned on the front lines for primary care and preventive services, as nursing is its own separate and distinct discipline from medicine. Nursing is wellness oriented with a role of being a wellness promoter and also connecting patients across all systems of healthcare. Nursing is not the tasks that we do, rather nursing is about educating patients, assessing the patient, and helping the patient achieve goals. And the restrictive practice environment in Michigan makes it difficult, if not impossible, for nurses to make a difference in the health of our communities. Currently, for first-time appointments, those are new patient appointments with a provider, it takes an average of 24 days to get that scheduled. And this is a 30% increase in wait time. In 2014, it only took 18 days to get scheduled as a new patient to see a physician. Fact, Michigan has a shortage of nurses and physicians. Michigan's healthcare organizations are having a difficult time filling all of their open positions. HRSA, or the Health Resources and Services Administration, notes that the nursing shortage is expected to continue through 2030. In Michigan, about a third of the nursing workforce is aged 50 or older and nearing retirement. This data does include nurse practitioners. This is a problem because there is an increase in the need for healthcare due to the chronic disease burden in Michigan. Nursing burnout is also a cause for many to leave the profession of nursing due to the lack of recognition for their contributions to healthcare and just being overwhelmed with all the care that needs to be given right now. And healthcare providers are expected to do more with less resources, and our current pandemic has really magnified that issue. The physician shortages are also related to burnout and age, as many are nearing retirement. HRSA projects that by 2025, Michigan will have a shortage of approximately 1,000 primary care physicians. Primary care and specialty care are not accessible in most rural areas and some urban areas in Michigan. This requires Michigan residents to travel further than the next county to receive appropriate care in some cases. And many Michigan residents require primary care and specialty care for management of their chronic diseases. With current laws, if physicians are not working in underserved areas, nurse practitioners can't work in those areas. And this directly impacts the health of our population. Mental health care is especially difficult to access in all areas of Michigan. Uninsured and underinsured patients have increased difficulties in accessing both specialty and mental health care. This includes patients that are covered by Medicaid, Medicare, and are uninsured. Fact, Michigan is one of the most restrictive states for nursing practice. So Michigan is one of only 11 states that has a restrictive scope of practice. Our restrictive scope of practice limits nurse practitioners from practicing at the top of their education and training. This is a reason many nurse practitioners leave the state after their educational programs have been completed. Michigan has many great universities educating and graduating nurse practitioners, but they don't stay in this state because of the barriers. Nurse practitioners are limited in their ability to work in underserved rural and urban areas because physician oversight is required for nurse practitioners to be able to perform most of the work they are educated, trained, and licensed to provide. In fact, nurse practitioners can help fill the gaps. Nurse practitioners provide high quality, cost-effective care as they are highly educated clinicians who traditionally practice in underserved areas. And studies do show that nurse practitioner care is equal to physician-delivered care. Fully recognizing nurse practitioner scope of practice will engage nurse practitioners to work in underserved areas in Michigan. And research does show us that in states that recognize nurse practitioner scope of practice, more nurse practitioners practice in health professional shortage areas. Nurse practitioners can improve access to care for the most vulnerable. These include our elderly patients, children, and those living in poverty. Mortality rates decrease in states that fully embrace nurse practitioner scope of practice. The literature tells us this is especially true for patients with cancer, heart disease, and stroke. These patients have lower mortality rates in parts of the US that have increased access to primary care. In critical care settings, research has shown that nurse practitioners reduce length of stay, reduce the time to consultation and treatment, and decrease mortality and morbidity. The literature also tells us that patient satisfaction with healthcare increases as interaction with nurses increases. This all adds up to healthcare cost savings, improved patient satisfaction, better patient outcomes because patients feel empowered to engage in their own healthcare. In fact, significant support exists for nurse practitioners. There are multiple policy influencing organizations that have supported utilizing nurse practitioners to the full scope of their practice for more than a decade. The list here on the screen are organizations that have just recently reestablished their commitment to this effort for nurse practitioners working to the full scope of their education and training. Most recently, the Institute of Medicine's Future of Nursing Report 2020 to 2030 was released and makes many salient points, such as removing restrictive practice regulations for all healthcare providers, stating that all healthcare providers should be utilized to the full extent of their education and training. Primary care is a common good, but access has to be improved. Telephone and/or video visits improve access, but not everyone can afford the data needed to support these technologies. Social determinants of health must be addressed. To name a few, transportation barriers, language barriers, and care has to be available outside of the 8 to 5 norm. And patients want to receive health care in their own communities. The RAND Corporation continues to work with state nursing leaders to create state-specific documents that speak to utilizing nurse practitioners to their full scope of practice. The Michigan Task Force for Nursing recommends that removal of restrictive practice regulations is necessary to cultivate the nursing workforce. Johnson & Johnson has long been a supporter of nursing, and they have run multiple and continual positive ad campaigns related to the role of nursing at all educational levels. AARP supports the use of nurse practitioners to the full extent of their license to promote wellness and support chronic disease management. Governor Whitmer's health agenda speaks to expanding access to affordable health care in Michigan to decrease the chronic disease burden. It also speaks to investing in public health and improving quality and health care. And I will expand on this part later in my presentation. So advanced practice registered nurse. This slide will provide a bit more clarification on this term. The nurse practitioner role falls underneath the broad umbrella of advanced practice registered nurses, or APRNs. This broad umbrella includes nurse practitioners, nurse midwives, nurse anesthetists, and clinical nurse specialists. So the Public Health Code defines nurse practitioners as registered nurses who have advanced education at the master's or doctorate level and advanced clinical training beyond their initial registered nurse preparation. They use evidence-based treatments and consult and collaborate with other healthcare professionals to provide quality, comprehensive care. Currently, Michigan has over 8,000 licensed and certified nurse practitioners. Nurse practitioners approach patient care from a wellness or health perspective. Our lens is focused on keeping patients healthy and or returning them to health. What we do day to day looks very similar to what other healthcare providers do, but we approach it from a different perspective. This graph details how the scope of practice differs between a nurse practitioner and a physician. As I previously mentioned, nurse practitioners are RNs first. The RN education is broad and general, and RNs are educated to care for all patient populations across all settings in the inpatient and the outpatient arenas. After the RN completes a bachelor's degree or a BSN, they then apply and complete a graduate program with specialized advanced education. This advanced education includes a specific population, and as the graph shows here, specifically pediatrics, adult, gerontology, family, psych, mental health, and so on. This specialty graduate education defines the nurse practitioner scope of practice. And that does, you can see there in the middle where it talks about pediatric acute care and pediatric primary care. So that does differentiate between population in the inpatient versus the outpatient setting. So the acute care pediatric nurse practitioner would work in an inpatient setting, where the pediatric primary care certification would work in the outpatient setting. And up at the top of the graph, a physician is educated across all patient populations and all settings in the inpatient and outpatient arenas. And then the physician goes on to specialize in cardiology, GI, so forth. But again, they're educated to treat patients in the inpatient and the outpatient setting. So to further drill down to scope of practice, this is important. Scope of practice is important as it ensures public safety and ensures healthcare providers are competent to perform their assigned duties. Scope of practice ensures the nurse practitioner performs duties according to his or her level of education, training, and certification. So the education, like I mentioned, is graduate education that is focused on a specific population and setting. And as I mentioned, as an example, pediatric primary care nurse practitioners would be educated to work in the outpatient arena. Certification. A nurse practitioner, after completing their graduate education, must sit for a certification exam and pass that exam that is specific to their population focus. So again, if you're educated as a pediatric primary care nurse practitioner, you would be certified as a pediatric primary care nurse practitioner and not as a pediatric nurse practitioner in acute care. Licensure. In Michigan, nurse practitioners hold an RN license and a specialty certification that designates they are a nurse practitioner. Currently, nurse practitioners in Michigan do not have a license as a nurse practitioner. Rather, they hold the RN license, like I said, and a specialty certification, but not a specific nurse practitioner license. This is all detailed in the regulations in Michigan. So to further round out the nurse practitioner education, I'll provide a bit more detail. So initially, the RN is educated with a BSN degree, then chooses to go back for an advanced degree or a graduate degree, either at the master's and or the doctoral level. So during that time, the student completes 1,000 hours of clinical time within that specialty population. So carrying on with my pediatric nurse practitioner example, that means that a student in a pediatric nurse practitioner program would complete 1,000 hours specifically treating children. And for each certification that a nurse practitioner holds, he or she has completed 1,000 hours in that specialty or that population. So each one of those has an extra 1,000 hours associated with it. For certification, eligibility is based on the number of clinical hours and education, and it is specific to the role and the population, as I talked about in the last slide. So we do have to maintain CEs or CEUs, and those are required annually. The number varies based on who you hold your certification with. We also have to hold or maintain certification, we have to have a certain number of CEs or CEUs to maintain our RN licenses as well. So the current law in Michigan says that we have nurse practitioners have practice authority through supervision by a licensed physician is required, and they delegate the task and functions to the nurse practitioners that fall under the nurse practitioner's scope of practice. Prescriptive authority is delegated for controlled substances. So we do have to have a supervising physician to delegate that authority to a nurse practitioner, but a nurse practitioner may prescribe non-scheduled medications. This would be, for instance, an antibiotic without the delegation of a physician. So getting into more detail on the governor's health agenda, and this information is coming right off of her website. The health of every Michigander is affected by factors ranging from genetics, the environment, the economy, and government policies. And these factors do influence both personal choices and access to health-related services. Establishing and maintaining the public health must include a new way of thinking to shape the goals and duties of every agency in the state government. So our governor believes one of her duties is to protect and promote the health and well-being of Michigan citizens. And additionally, everyone has the right to quality, affordable health care. So the governor's agenda speaks to achieving greater health outcomes by focusing on making healthcare more affordable, expanding access to healthcare, improving quality, and investing in public health. Fully recognizing and utilizing nurse practitioners in Michigan aligns perfectly with the governor's agenda. So to that end, we will talk about the bill that has been introduced. And I apologize, I know this is a busy slide, but I wanted to get as much information on it as I could. The Michigan Council of Nurse Practitioners worked with Senator Rick Outman to draft bill language to address the scope of practice issues for nurse practitioners. So Senate Bill 680 was introduced on October 5th. And Senator Outman says this bill will give nurse practitioners the ability to practice to the full extent of their education and training, and will expand access to care, improve healthcare quality, and invest in public health. So again, aligning very well with the governor's health agenda. This bill currently sits in the Senate Health Policy Committee. And as you can see from the list of co-sponsors, there is bipartisan support for this bill. This bill outlines the requirements that must be met by a professional nurse to be recognized as a nurse practitioner in Michigan. And it specifies the scope of practice of a nurse practitioner, which includes, but is not limited to, performing comprehensive assessments, providing physical exams and other health assessments, and providing screening activities, diagnosing, treating, and managing patients with acute and chronic illnesses and diseases, ordering, performing, supervising, and interpreting lab work and imaging studies, and prescribing pharmaceutical and non-pharmaceutical interventions and treatments that are within the nurse practitioner's specialty role. It will also amend the Public Act 368 of 1978 to insert language allowing the administrator to issue a controlled substance license to a nurse practitioner. That means that a nurse practitioner would no longer have to have a delegating physician to be able to write for controlled substance if and when that was necessary in the nurse practitioner's practice. Why is this type of legislation so important? It allows nurse practitioners to work how and where they would like, and provides flexibility and ability to choose practice settings and work in underserved areas, even if physicians aren't working in those areas. It will increase patient satisfaction, accessibility, and improve health outcomes. This legislation will give 500,000 Michiganders improved access to care within their travel capabilities, and allow nurse practitioners to work together with professionals from different disciplines to find the best options for patients' treatments. It will remove barriers to access to care, as I discussed earlier in the presentation. It improves transparency. The nurse practitioner's name will appear on all prescription bottles, lab orders, imaging orders, and lab and imaging results will come back to the nurse practitioner and not to a collaborating physician who may never have seen the patient. The ability to be, it will also provide the ability to be credentialed by all insurance companies, as nurse practitioners will be recognized as providers. This makes nurse practitioners no longer invisible providers. Patients can locate a nurse practitioner and see a nurse practitioner if this is their provider of choice. To date, 27 states have already modernized their practice regulations. Again, this year, the Gallup poll names nurses as the most trusted profession. As you are probably aware, nursing has been named the most trusted profession for the past 20 years, with the exception of the year 9/11 occurred. The firefighters took the top spot that year. So we know the public trusts nurses. Nurse practitioners have the education and training to improve access to care. The literature or the research shows us that nurse practitioners provide high quality, safe, and cost-effective care. And healthcare data shows us that in areas where nurse practitioners practice to the top of their education and training, these geographic areas have a decrease in the chronic disease burden, and this translates to lower morbidity and mortality. So thank you for listening, and I am happy to answer any questions.
All right. Well, thank you so much for presenting, Dr. Sheehan. It was a really much needed topic. I thought your discussion just gave a lot of great reasons about why this legislation is needed and really the challenges that certain populations in our state are facing with access to care. So with that, I have a couple questions here. And again, for those of you listening, please go ahead and type them into the box, the Q&A box. She'd be happy to answer. The first question I have is, some people believe that Senate Bill 680, which is one we just discussed, would increase the scope of practice for NPs beyond their current level of education and abilities. Like, what would you say to that?
And as I described in my presentation, it's very well defined what the scope of practice for a nurse practitioner would be. The scope of practice is determined based on the education, training, and certification. So no, this bill would not allow a nurse practitioner to practice outside of the scope of practice that is determined by the education, training, and certification. So it does not take any of that away. And that is that scope of practice that's determined by education, training, and certification those are national standards, not just something that happens in Michigan.
Great, thank you. I got a couple in the chat box. We have an anonymous attendee who, with the question, with bipartisan support for the bill, what are the predictions for passing this year? We have tried this before and been unsuccessful, which you and I spoke about before the call, but what do you think makes it different this year?
Right. Well, this year, I think there's a couple of things that make a difference. Number one, I think the pandemic has made a difference. And that's one thing I did not touch on now that the question came up. So I'm glad somebody did ask this question. During the height of the pandemic, many states, and Michigan was one of them, that scope of practice restrictions were lifted for all healthcare professionals, so that it was viewed as okay or acceptable for people to work to the top of their license. And some people were at that point working outside of their scope of practice. For instance, I know I keep going back to the pediatric example, but I'm a peds nurse practitioner, so all of my examples seem to come from that venue. But I know several of my pediatric colleagues who are in acute care were pulled to adult ICUs to care for COVID patients because the need was so high. So in this case, I think we have proven that there was no harm done. So I think we've got that on our side. Last year, about this time, the nurse anesthetists were able to get a full practice authority bill passed in Michigan. So I think we've got that momentum going in Michigan. And I think now with the pandemic, we have a greater realization across the board that healthcare is not equal in all areas of Michigan. And we have to figure out a way to get healthcare to more people in their areas. And clearly, physicians, we're going to have a deficit of physicians. We're going to have a deficit of nurses too, but it's going to take all of us to get this job done to take care of Michigan.
I agree. Next question. So you talk a little bit more about what you think will happen with this legislation, and then what are some of the current barriers? Who's against it and why?
So yeah, what I think will happen. We need to get it moved out of the Senate Health Policy Committee, and that's going to take all of us writing letters to our senators and encouraging them to encourage those members that sit on the Health Policy Committee to take this bill up and get it out of committee and get it onto the floor. Once it gets out of committee and onto the floor, then it can be debated and voted on. And once it's successful on the Senate floor, then it can move into the House. And quite frankly, of course, the Michigan State Medical Society has been in opposition of this bill each time we've introduced it. I have not been involved in any discussions with them yet with this go around, but I would assume they're going to have the same objections to it that they've had in the past, which include things such as nurse practitioners don't have the same education as physicians do. And again, hopefully I made that clear that we aren't saying that we've got the same education. We've got different education and focus. And our focus is on a little bit different than the physician focus. We're more wellness minded than illness minded, but still the outcome, both sides are looking at the same outcome of better health for the population. So sorry, I think I might have missed part of that question. Did I answer all the parts of it?
I think you did. I mean, sounds like you're cautiously optimistic.
Yes, yeah, and yeah, unfortunately, it just got introduced on October 5th. So like I said, I haven't been engaged in any discussions about it yet. I know my personal senator, his reaction to it is he'll talk more about it once it hits the Senate floor. So I just need to work more on him to get him engaged in the process right now too.
Okay. All right. Next question is from Eleanor Haas. I think this is a great piece of legislation. However, I'm wondering if increasing the scope of practice for NPs will encourage more BSN RNs to go into higher education, and will this contribute more to a nursing shortage at the bedside? It's a good question.
It is, and it's a fair question.
Yeah.
I don't think that is going to be an issue, quite frankly. I think nurses who have that, and that desire to go on for an advanced degree are going to do that, which we've proven because we graduate a lot of students in our nurse practitioners in the state of Michigan. So they're going to school even though we have practice barriers. So I don't see that changing a lot just because the practice barriers go away. I think what we're going to see happen if the practice barriers go away, our access problems are going to get better because we'll be a better environment and can attract providers to come to Michigan to practice so that our shortage won't be as dire as it looks like it's going to be.
I
think probably the opposite is going to be true, that we'll get more people transferring to Michigan more than taking people out of the traditional BSN RN role.
Mm-hmm. Yeah, and you mentioned earlier that a lot of them are just leaving the state. So actually stopping that brain drain and keeping them here. So
exactly.
I agree. Mary May, question's pretty simple. You touched on it earlier. You might want to reiterate it, but what can I do to get it passed?
Great. Is to talk to your senator. The Senate is where this bill sits right now. So talking to your senator about it. There is a lot of information at the MyCamp website, which is micnp.org, that I think the general public can access for talking point documents. If you can't access it, I am happy to help you access that information so you've got some talking point documents to share with your senator. But talking to the senators, encouraging them to get this bill taken up in the Health Policy Committee so we can get it out of committee, get it onto the floor, and get a favorable vote so then it can move on to the House.
Great. All right. This question is anonymous. So clearly there is a mental health crisis in the country, even pre-pandemic, which I'm sure we're all aware. Has mental health care lobbyists, activists, and organization become involved with support of this bill? And they had, I would hope so.
Another great question. And I don't have an answer for that. I don't know if we have tapped into that community of healthcare professionals yet, but that is definitely someplace we do need to go, because absolutely, yes, we need that healthcare, or excuse me, that mental health component for sure.
That's a great question. All right, next question. With all of the health prevention programs embraced by various insurance companies and corporations. Is there support for these entities to increase prevention and treat chronic illnesses in rural and urban communities to save money by utilizing more NPs?
Well, that's kind of a double-edged question there. There are, because the insurance companies want to have patients to have local or geographic access to health care. And they do know that these preventive services do save money in the long run. Now, are they actually invested in this legislation? They have been very cautious about providing their support for this type of legislation in the past. So I don't anticipate that that's going to change this time. But I think that's we, the nurse practitioners, the nurses, need to work on that entity also. And I know with my camp, we do have a full plan ready to go for that too, to talking to the hospital administrators, the insurance companies, those kind of things to gain that support. But anything you can do from your perspective, if you are a nurse practitioner, talking with the healthcare organizations that you're credentialed with would be helpful to hear the stories, the issues that you're having or that your patients are having. Personal stories are always the best to get any action, because talking in general terms doesn't always compute with some people, but legislators and healthcare organizations, I think, respond more to personal stories.
That's good to know. The next question we have is from Julie Thomas Beckett. She's a fellow Spartan nurse practitioner. Her question is, what does it look like once the bill gets to the House? Is it promising to pass through the House to the governor's desk?
Through the House, again, we are talking with the House. We had hoped to get this introduced in both branches at the same time, so it could have a little bit speedier of a process. But we didn't find a sponsor in the House, and that's why we only introduced it on the Senate side. So we don't have to have a sponsor once it comes through the Senate side for it to get to the House. So again, once we get it voted off of the floor of the Senate, then we've got to do all this education of the representatives to make sure it does pass through the House as well. So I'm sorry to say that I don't know. Yeah, I don't know what the temperature of this is in the House right now.
Okay. Another question from Julie. Are insurance carriers supportive of this bill and using their lobbying muscle to get it passed?
So talking about the third-party payers like Blue Cross and Blue Shields of Michigan and those kind of things, is that who it is?
I believe so. I'm assuming she's referring to healthcare.
Okay, so yeah, I kind of alluded to that last time, that they've been very cautious about providing support for it in the past for this type of legislation. But again, my camp has a full agenda for how we're going to approach this and talk to different entities, including the third-party payers or the insurance companies, right?
All right. Looks like Dr. Terry Weirwine, she put in the chat. So as she says, as I recall, as a senator, the governor did not support the previous bill for nurse practitioner practice. Do you know what her position is at the time with the new initiatives that we have?
Right. Yeah. Great question, Terry. I know you and I both sat through that one. She actually, the governor, our current governor, is the reason why it was a couple times ago, but it didn't pass. She is cautious about it, but I expect that she will sign it if it goes through, because she did sign the bill for the nurse anesthetists. So that's why I'm hoping we're using that momentum from that bill passing, that we can get this through and get it signed by the governor. So I have not heard that she would oppose this legislation. And I'm sorry that I'm not armed with great information about the temperature of the Senate and the legislators and the governor just yet, because this campaign is still so new. We haven't really been out talking to a lot of people just yet. So, but yes, Terry, I do remember that. And I cringe at that thought also. And that's crossed my mind many times too about this legislation.
Mhm. Another question from Eleanor Haas. She knows that this has been presented to the state before. I guess, so she's asking what's different about it now that might make it more likely to pass.
Yeah, what's different this time is it is only addressing nurse practitioners. Now, several iterations ago, we tried to get it to go through for all 4 of the APRN roles at the same time. That's why the nurse anesthetist branched off early. They've been working on their own full practice authority for a number of years because the anesthesiologists have such a strong lobbying component. Thought that we would be more successful without the nurse the nurse anesthetist attached to it. And that hasn't been so. Now, last go round with House Bill 5400, we got a lot of pushback on this bill related to the clinical nurse specialists, because they, a lot of people didn't feel that they needed to have prescriptive authority. So we thought it might be cleaner to just approach this with the nurse practitioners only. We're only talking about one role. We can clearly define that role, and we're not having as much gray or ambiguous areas we might have with some of the other roles. So that's what's different this time, is we're only talking about full practice authority for the nurse practitioners.
Okay. I have a question from Angie Strawn all the way out in California. She says, I live in California and this state has fought this battle for years. Just earlier this year, success was achieved for APRN's scope of practice. Have you looked at what led to success for NPs in other states to achieve?
Oh, yes. Yeah, and we are working very hand in hand with the American Association of Nurse Practitioners, AANP. Their state, and I can't think what the name of that group, what that subsection of AANP, there's state lobbying. I don't think that's the right thing, but yeah, they are working hand in hand with my camp on this. And yes, they are bringing lots of examples of what worked different places. And we are very different here in Michigan, because most states have not been successful passing full practice authority one role at a time. They've been more successful trying to get at all 4 roles at the same time, where we're just having the opposite experience here in Michigan. So, and I know California did just pass, I think it was about a year ago, passed their full practice authority bill. But I wonder, I haven't dug down into it, what's not quite right there, because AANP has not turned their state green yet. So I don't know, what's going on there, which that means that the American Association of Nurse Practitioner Organization doesn't recognize them as a full scope of practice state. So I don't know what's going on in that legislation, but
yeah, I wonder where
yes,
the lapse
we are.
is.
I'm sorry, what?
I just wonder where the lapse is at there, why it's green somewhere and then it's not recognized.
Right. Yeah. So something tells me that there's still some tie to a physician or other health professional that makes it not fully autonomous. So yeah, that piece I'm not sure of. So, but yeah, we are working with other states and talking to other states, and yeah, we've brought in lots of other leaders from these campaigns from other states to talk with them. In the past, even when we've introduced other legislation. So yeah, Michigan just struggles with this.
All right, well, Dr. Sheehan, that's all the question. Nope. Oh, well, Angie, she just put in here that she's open to an offline conversation. So I'll be happy to pass you along her contact info. I'm sure you two could exchange some
Perfect.
information.
Yep, that'd be great. Perfect. Thank you.
All right. Well, besides that, I don't see any questions here in the chat. So with that, thank you so much for presenting on this topic. We appreciate it. And then thank you to all of you for joining us. Just stay tuned. You're going to see some communications coming from our office with a YouTube link to the presentation if you want to watch it back and maybe refer to some of the materials. And then if you're interested in keeping up with the college and other communications, you can follow us on social media at Mich State Nursing. So with that, thank you again, and take care, everyone.